everyone, and welcome to the Thai Society for Head and Neck Oncology's webinar series. My name is Patravut Vatanasap. I'm the past president of the society and currently at the Khon Kaen University, Thailand. So we have organized the webinar series in head and neck oncology, head and neck surgery since after the COVID time in every month. So it is this time is very special because we have a guest speaker and we have hold it in international with the international participants today, and the topic it's one of the major problems in our region and is very challenging. So even though we are the head and neck surgeons in the old day, we always say, oh, it's nasopharyngeal cancer, just refer to the radiotherapist, but there are many more to know about that, and especially in the current era of the personalized medicine. So today, it is our great honor to have our colleague from Singapore. He is the world leading expert and also researcher in the field of nasopharyngeal cancer and head and neck cancer. And not only the researcher, but he's also a prominent professor and clinician who expertise in robotic surgery, minimally invasive surgery. So we now very glad to welcome Professor Chwee Ming Lim. He is the senior consultant at the Department of Otolaryngology, Head Neck Surgery, Singapore General Hospital, also director of the Department of Clinical Translational Research, Singapore General Hospital, and the senior consultant at the Sing Health Duke in US Head and Neck Center. He also involved in many organizations and lately with the APTS that is going to be the next host in the next couple of years. So we will learn a lot from this authentic lecture from Professor Chwee Ming Lim. So please welcome Professor Lim. The floor is yours.
Hi, good evening, everybody. Can everybody hear me well? Yep.
Yes.
Good. Thanks so much, Petravut, for the kind introduction and also for the invitation to be in this webinar. So I will be sharing my screen now and just want to check if everybody can see the screen well. Okay. All right. Thanks again for this invitation. So I've been tasked to speak about the early diagnosis as well as management of NPC. I'll probably focus more on my attention on the recurrent cancer. But I just want to acknowledge that the training I have with UPMC way back in 2010, and just some of the alumni from Prof. Jean Myers and also Prof. Peter Howe, who is one of the champions for the Asian National Society. And just want to also congratulate the Thai colleagues for organizing a very successful APTS, and also for Petravut for igniting the floor with his livelihood and the band. All right, and also the Thai friends that I've made over the years, and really appreciate the friendship and that that we can have all these years. All right, so moving on to the lecture right now, I have divided the talk into two portions. The first one is in terms of the early diagnosis / screening of NPCs. And I'll discuss the overview of this subject, talking about some of the endoscopic options for screening and some of the more research area where we can use AI technology for image segmentation and risk stratification for NPCs. In the next portion, I will go through an overview of NPC and particularly focusing on recurrent NPC. And as surgeons, how do we manage this group of cohort patients with recurrent diseases by some clinical examples. And finally, I'll end off with some of the future directions in terms of early diagnosis, liquid biopsy, and clinical trials, where surgeons can be, leading and driving some of this initiative for patients with recurrent disease. So NPC certainly is not an uncommon disease in our area, like what Petravut have mentioned. Certainly in this area, highlighted in Southeast Asia, certainly we do see a fairly high proportion of patients with nasopharyngeal cancers. So over background, this is also a fairly common cancer locally in Singapore. It's highly endemic in southern China and Southeast Asia. Unfortunately, about 70% or so of this group of patients are detected in the locally advanced cohort with nodal metastasis at the diagnosis. And what is also concerning is among those recurrent locally advanced disease, about 20% will recur after definitive treatment. So the clinical presentation of NPC, largely patients may present with masses in the neck like lymph nodes. Not uncommonly, they present with blocked ear following otitis media with effusion. Occasionally, they may present with blood stain and less so with frank epistaxis. In advanced cases, they may present with cranial nerve neuropathy. And of course, a sizable cohort of patients may be totally asymptomatic. And that raises questions whether a screening program can be adopted to pick up this group of patients. So this is just some clinical examples with patients with nodal metastasis, as you can see on the coronal MRI, multiple method lymph nodes along to level 2, 3, and 4. And in this particular patient, what was interesting was that the tumor is actually fairly subtle. And if this is only picked up, you can appreciate that there is this effacement of the fossa rosemola. And on MRI, you can appreciate that this is associated with a retropharyngeal lymph node, which is the first echelon lymph node metastasis for NPCs. Certainly, otitis media with effusion is also not uncommon. So any adult with unilateral otitis media effusion mandates an endoscopic exam of the nasopharynx. Epistaxis, largely frank epistaxis is not uncommon. So rarely they may present with epistaxis that for locally advanced disease that require posterior packing. And certainly locally advanced disease can also manifest as cranial nerve neuropathy. Rarely they present very extensive because the disease may goes deeper to involve the parotid gland, although this is uncommon. The area that we want to focus today is whether we can pick some of these patients who are largely asymptomatic, that they are sometimes referred to us because some abnormality was picked up on imaging done for other reasons, like in this patient who picked up with a second malignancy with NPC on the PET scan. And sometimes they pick up very small, subtle disease that you can see on the nasopharynx because they are seen for unrelated ENT complaints and was diagnosed with incidental NPCs. Some patients are also picked up with raised EBV, which is a serological risk marker for NPC because this is a viral-driven cancers. And this is only picked up because of screening abnormalities with raised EBV and was eventually biopsy proven to be nasopharyngeal cancers. So, so with that, it's also not uncommon that sometimes patients come to see us for like a upper respiratory tract infection symptoms, and on endoscopy by ENT colleague picked up with asymmetrical enlargement of adenoidal tissues. And this, my policy is anyone with adult presenting with what seemingly look like adenoid tissue, I typically would prefer to biopsy them. All right, so this is just to give you a flavor of the clinical presentation on the nasopharynx. So with this understanding, why is there a rationale for screening? Because this is locally, at least in Singapore, is the commonest head and neck cancers. And there is vast survival differences between patients diagnosed early, meaning stage 1 or 2, versus those with locally advanced disease, stage 3 and 4. And current epidemiological data suggests that we're picking them far too late, about 70% presenting with nodal metastasis, indicating more likelihood of a locally advanced disease at the outset. And also with the increasing technology advances, especially with these EBV-driven cancers, there are available techniques that are now available, either during serology or PCR, that can help inform risk stratify patients for a screening program. So locally in Singapore, this is the current guidelines in our country. We don't advocate mass screening for a healthy general population for EBV serology. For those patients with 2 or more index cases with a positive family history of NPC may be screened using both endoscopy as well as EBV serology against the VCA and the EA. And based on previous published data, we have found that the general healthy population, Chinese in Singapore, this will be a ballpark figures for anti-EBV VCA and EA, IgA serology, and anything above that threshold, generally we would want to have a careful look on the nasopharynx. In terms of endoscopy examination, the current standard using the white light is pretty routine in our ENT practice. Certainly, other groups have explored the use of narrowband imaging to see whether they could pick up early diseases. I shall elaborate on that later. And also other nuances like a spectroscopy techniques, which I still under research protocol, which I am able to share some of the data that we have. One thing for sure is as ENT specialists, if you see this nasopharynx on the endoscopy on the left side, where there's effacement, I think what we need to do is really try to decongest the area by putting a cotton plaquettes with eliodine and then re-examine the area about 5 to 10 minutes after. Some physicians have advocated doing a transpalatal endoscopy exam of the nasopharynx. As you can see, you can really see the fossa of Russa molar very clearly if you look at from the transpalatal view. And this may be a helpful adjunct for equivocal cases, which we shall touch on. So this was the one of the studies that we published previously on narrowband imaging. And I think other groups over the years have also likewise published. The overall consensus is, although there are particular features on MBI, on NPC versus normal nasopharyngeal tissues, unfortunately, these changes are not sufficiently early enough for us to preclude the onset of NPCs. So based on most publications, we have not found this to be particularly useful as a precursor for detecting abnormality of the nasopharynx before a frank malignant disease occurring. So these are some of the current challenges with our current practice. When we see a suspicious tumor on the nasopharynx exam, then we do a biopsy and then follow up with pathology to confirm the diagnosis. And this certainly is asking the question whether we would be using a more rapid and objective tool for NPC detection. So what is this thing called Raman spectroscopy? This is one of the optical techniques that has been used. It was first described by the Professor Raman, I think way back in the 1930s. And his work of this Raman spectroscopy has earned him a Nobel Prize at that time. Certainly, this spectroscopy is useful because it can allow a detection of biochemical information of different nucleic acids, DNA, carbohydrates, and then we can have a molecular fingerprinting of the tissue that we want to establish these Raman signatures. So what can be done is we can build this Raman spectroscopy fiber into the current endoscopy system. And you can see this is how a cartoon showing how it may look like, where you can put a probe attached to a Raman system. And then you can potentially then put this probe over the tissue in question and decide whether this tissue is suspicious. If it's suspicious, then it gives you an idea that this is likely abnormal tissue and mandates a deeper interrogation with tissue diagnosis. So this is why we envision this Raman spectroscopy to be used in the clinic. So over the years, the team with Prof. Wang, which is the engineering lead for this collaboration, showed that we are able indeed to use real-time diagnosis of NPC using this rapid fiber of Raman spectroscopy. So in this study, we profiled 92 patients with either NPCs, healthy nasopharynx versus post-treatment following definitive treatment with radiation. And we find that between cancer and healthy tissues, there are very distinct Raman signatures between these two cohorts. And this is just a plot to show that the in vivo Raman spectroscopy between NPCs and non-tumor tissues are fairly distinct, especially at these two peaks highlighted here at 2885, between 285 and 2940. And this has been correlated by previous studies that a particular peak will correspond with different changes either in the amino acids or lipid content. And this gives an added advantage in terms of understanding the distinct biology between NPCs versus healthy tissues. right? So this is just to show how the Raman will show certain peaks are up-regulated, certain peaks are now regulated corresponding to the various platform. And you can see this is how it looks in a composite fashion. And using a data analysis and modeling using a PCA kind of analysis, we were then able to separate out the Raman signatures between cancer and normal tissue with fairly good sensitivity and specificity data, with an overall accuracy of approximately 93%. All right, so certainly the other problem that we see is in terms of NPC patients after treatment, how do we survey the nasopharynx? Because sometimes there may be scar demonstrating either on imaging or on endoscopy. And this is what we believe may be helpful to use Raman spectroscopy to use an added layer of triaging. As you can see, these are patients after treatment. You can see the nasopharynx is scarred. And by putting a Raman spectroscopy, we asked the question whether we could use this to do surveillance in addition to white light imaging. And with that, we can show that by adding on a deep learning fiber optic analysis, we can actually separate out three distinct conditions. One is NPC at diagnosis with frank tumor. Number two is those patients who had treatment for NPC but is currently in remission. And these are post-treatment nasopharynx. And the third one will be those patients with healthy looking tissues in the nasopharynx, such as lymphoid hyperplasia. So with this, we can show that we were able to distinguish the signals between three disease states. And using this data set, we are able to show that there is distinct sensitivity and specificity of these values accordingly. All right, so with that strategy, certainly how then we ask the question whether we can use AI strategy for NPC screening. Certainly, NPC may not be readily available for certain community setting where they do not have the endoscope to look at the nasopharynx. So we asked whether we could have a kind of triaging kind of information for somebody who is trained to do endoscopy but may not have the necessary experience of an ENT specialist, and how can we use this image segmentation for early detection and screening, and using the AI algorithm to be built into an existing endoscopic system. This is a video to show how this looks like. You can see that so you can see that this is how the endoscopy of the view looks like for the healthy and the tumor specimen, tumor patient. And using this video endoscopy signals, videos, images, we're able then to ask whether we could build this into a AI model. And we believe that there is a potential difficulty, especially among primary healthcare physicians, to distinguish between cancerous and non-cancerous tissue in the nasopharynx. So we want to see like this is cancer, no cancer, not cancer, and then we can have these areas, these images being annotated, like in this normal, this is NPC, and this is adenoid tissues. And we can then build this into a neural network kind of analysis platform. As you can see, we can build this through a series of neural network to say yes, no, yes, no. At the end of the day, we want to come up with a final convoluted analysis and see whether the likelihood of this image harboring NPC is there. So this is what we did. And this is just to show the video how it could potentially look like in the clinical context where this algorithm is built into the current setup. So this is just to illustrate that. Just a minute. Yeah. Hello? Yeah, so this is how it looks like. You can see that as the endoscopy put in the scope, if there's an abnormal signal, it will light up as a bulb so that you could warn the person that doing the scope that this potentially could be an NPC, and certainly would then allow the physician to then refer the patients to an ENT specialist for a formal biopsies and evaluation. All right, so how this has dovetailed over the past 5 years from the 2019 screening protocol. Recently, we published a local consortium guidelines. How do we then built in a screening algorithm among those patients with positive family history of NPC. You can see we can do the normal EBV and endoscopy as the first cut, and we can then divide patients with suspicious lesion would then be biopsy. If the patients have a normal looking nasopharynx, there are a few strategies. We use the titers of the EBV serology to guide us. Either we can add a plasma EBV DNA as one of the adjuncts to risk stratify this group of patients, or we can also use the MRI of the PNS, which was much published in Hong Kong by our Hong Kong colleagues, and then to decide whether we need to do further intervention like a biopsy, sometimes under general anesthesia because of deep-seated lesions, and then to build up this screening algorithm for screening patients with a positive family for NPCs. Yeah, so with that, I just want to highlight a particular case that I still do not have any solutions. Maybe you can provide some of your inputs. For instance, like a generally healthy lady who was picked up with a screening or NPC because of a positive family history, a raised EBV serology, but has been screened since 5 years ago, repeatedly normal serologies, normal endoscopic findings, but with persistently raised EBV serology. We did an EBV DNA that was also detected. This is how the nasopharynx looks like. Yeah, how do we manage this group of patients, even using the transpalatal endoscopy, MRI, which did not pick up any concerning lesions? I don't have any solution. How long do we monitor this group of patients with persistently raised EBV, but seemingly normal endoscopy findings and MRI? It may be related to the virus biology in terms of the latency of the EBV virus transiting into a lytic phase. Do not have any clear ideas at this point, but this is certainly some of the conundrum that we see in our clinical practice. So for the first portion, certainly NPC screening is useful, especially among individuals with a positive family history. And I think for ENT specialists, head and neck surgeons, certainly endoscopy remains highly relevant to examine the PNS, the nasopharynx carefully, and using currently additional techniques or adjuncts such as spectroscopy techniques with or without AI capability can then be built in to scale up the integration of this screening protocol, either in a community setting or in a larger scale of things. All right, so the first part of the talk is on screening and early diagnosis. Now I'd like to move on to the second part, is a new paradigm of treating recurrent NPCs. So you can see that this is the overall paradigm for managing NPC. Certainly early versus advanced stages have different treatment paradigm. And certainly there's a group called oligometastatic. Now we understand the biology that we sometimes give definitely concurrent chemo radiotherapy because this has been shown to improve survival in those with oligometastatic diseases. I'd like to focus primarily on the recurrent non-metastatic cohort because that would typically involve us as head and neck surgeons to help to manage this group of patients. Right, so this was a paper published in a local context in Singapore where we have a multi-ethnic group, and we certainly found that the general outcome of NPC patients mirrors quite closely to the other published data in Hong Kong and southern China. And we find that the advanced nodal disease as well as presence of distant metastasis are certain poor independent markers for survival. And among our data as well as others, we found that the proportion of patients with recurrent NPC is about 10 to 15%. And in this particular patient with non-metastatic recurrent NPCs, then surgery is the mainstay for local regional control. Most people will agree that recurrent T1, T2 disease are amenable for surgical salvage, and for a very small proportion of select T3 cases, locally advanced T4 recurrent disease are typically not candidates for surgery. So this is a randomized phase 3 controlled study where performed in Sun Yat-sen Cancer Center, where they compare between endoscopic resection of recurrent NPC RT1 and RT2 versus re-radiation. And they found that the endoscopic treated cohort of patients have improved overall survival compared to re-RT in this randomized controlled trial. And this is to show the survival curves between the surgically treated versus the re-RT cohort patients, demonstrating that surgery, whenever feasible, should be the preferred way of treating recurrent NPCs. And what is also noteworthy is when you look at the complications of either the surgical cohort or the VRT cohort, you can see that the prevalence of grade 4 and 5 complications are certainly much reduced in the surgical arm. At the same time, the retreatment with locally recurrent NPC, there are also some concerns about treating this group of patients. And this is a paper by our radiation colleagues at National Cancer Center, Singapore. And they basically look at the factors that would be negative prognosis factors for treating recurrent NPCs. And these are some of the findings: RT3, T4, large tumor volume, the type of histology, the time to recurrence, and the viral load of the EBV were all negative prognostic factors in this group of patients treated with VRT. On the surgical front, we have published a multi-center review where we look at the practices of surgeons in Asia, treating this recurrent NPC with surgery, and we review some of the approaches that can be used, be it a endoscopic, a robotic arm, open surgery, and whether it's a maxillary swing or facial translocation, and other means of open surgery that can be used to treat recurrent NPCs. And I think for the natural orifice, most surgeons and also our rhinology colleagues are fairly comfortable using the transnasal approach, either with or without a transpterygoid, in order to get better exposure. And these are some of the pros and cons for the different natural orifice approach. I would think that most of the surgeons would prefer a purely transnasal approach because that's quite intuitive with our training using the endoscope system. Right, so to answer that, certainly we want to pick up this recurrence early as possible, because when they are picked up fairly early, like RT1, they make it more likely to be an endoscopic approach rather than an open approach. This is to show how a open approach of a nasopharyngectomy will looks like. And you can see that the lateral boundary will be the internal carotid artery. We are limited superior by the skull base, and not uncommonly the clivus may be exposed. And certainly with this defect, we will need to have a reconstruction with a free flap reconstruction to resurface the nasopharynx and protect the carotid artery. Unfortunately, about 60 to 70% of these candidate patients are not resectable because of gross invasion into the intracranium or encasement of the internal carotid artery, making this not a surgical candidate. And certainly sometimes the disease progresses a bit more endophytically, as you can see with skull-based recurrence that's proven on biopsy. Very subtle areas, but this was proven to be recurrent nasopharyngeal cancers. Also, NPCs is very unique in the sense that sometimes they recur in very odd places. Like in this case, patients present with a fullness on the forehead, and this was eventually biopsy and proven to be recurrent cancers. So this certainly is not a candidate for surgery. And this is how a endoscopic nasopharyngectomy would look like after surgery and then a nasoseptal flap reconstruction. And that certainly aids in the healing and resurface the nasopharynx post-resection. When we talk about open surgery approach, I think most people are probably familiar with the maxillary swing, because this affords the excellent exposure of the nasopharynx, and as well, including the lateral aspects of the defect is fairly well visualized. The only cons is about 10% of this group of patients will have the risk of a palatal fistulas. So this was pioneered and described by Professor William Wei from Hong Kong. And since then, I think many surgeons have adopted this approach in salvaging nasopharynx. So these are examples of recurrent NPC with this patient involvement of the sphenoid floor. And this is how the incision will look like for a maxillary swing approach. And this is to show the defect, the nasopharynx after the swing is completely performed. And this is a video just to illustrate the extent of a complete exposure that you can afford with the maxillary swing approach. And you can see the nasopharynx either through the headlight. I certainly also use the endoscope to guide me as we do this sort of open approaches. All right, you have seen this. This is how the defect may look like after nasopharyngectomies. This is another example, small recurrence, but they are far too lateral to allow us to have a good comfort of managing internal carotid artery. So we elected to do an open maxillary approach in this particular patient. And this is just to show the boundary of the defect after resection. Certainly the pharyngeal basilar fascia, which is this glistering white layer in the posterior aspect of your defect, certainly serves as a good barrier for cancer. And certainly this is the area that we want to see being preserved whenever possible for nasopharyngectomies. All right, so this is some of the post-op pictures of patients who had surgery during the maxillary swing. You can see the cosmesis aspect usually is quite well hidden if the incisions is placed fairly in the natural skin fold, and trismus is usually not a major issue. Palatal fistula is more a concern. Yeah, so unfortunately, quite a large majority may not be surgical candidates for salvage. And also, when you review the imaging, be mindful of very subtle features such as perineural invasion, as illustrated in here, and significant clival invasion, erosion that will preclude a surgical salvage for this group of patients. Just remember occult unusual sites, such as here in the frontal sinus, that sometimes may be cancers, and not forgetting the mid-grade mimicker, the osteoradial necrosis, in this group of patients that may mimic recurrent disease as on the imaging. So this group of patient is important for you to repeatedly debride the nasopharynx and then prove that there's no residual cancers. And if need to, you may consider some kind of nasal flap reconstruction to cover the exposed bone after adequate treatment. For neck recurrences, most people will advocate a modified radical neck dissection. This is just to illustrate the examples of the defect after modified radical neck dissection. For patients with isolated retropharyngeal lymph node metastasis, like in this case, I favor typically an open approach, although some groups have looked at pure endoscopic resection for isolated nasal retropharyngeal lymph node metastasis. The reason I would like to highlight is because this area, this is not a patient with NPC, but this is a patient for other head and neck resection. You can see, appreciate that the retropharynx space is really in this area, demarcated by the star, and the posterior medial lateral relationship is the internal carotid artery, which I feel more comfortable using an open approach for retropharyngeal lymph node metastasis recurrences rather than a purely endoscopic approach. So in terms of new developments for salvage, certainly we are familiar with the single port system that has been already used in some centers in Asia and many centers in the United States. So this is the previous flexible robotic system, the Mac robot. Certainly this is, you can use a transpalatal to like a snake-like movement to navigate the robotic arm through a single port system, transpalatal. And this is not a real patient, but this is more like a cadaveric dissection to show how this looks like on the console. So you can see this is viewed from the upside down position because you're coming in from the transpalatal route. You can see the two eustachian cushion. So certainly using this flexible system with very fine instruments, you are able to do a nasopharyngectomy possibly. And this potentially have advantages for very isolated recurrences in the nasopharynx, as you can see from this video. And this is just to make the superior cut of your resection. You can make it until you see the muscles, and then once you see the muscle, you can then peel it down downwards, and then can take out the nasopharynx in an en bloc fashion. And then this is the attachment of the prevertebral muscles, where you need to severe that before you can free it of the nasopharynx. Right, so in the interest of time, we just fast forward, and this is just to show how the portion of the eustachian cushion will forms the boundary, the lateral margins of your endoscopic resection. And you can then, once you sever the eustachian cartilaginous eustachian tube, then you can actually peel it everything down inferiorly, and then deliver the specimen orally like that. And this is how the defect will look like after resection. After this, usually we will lay some tissue glue, fibrin glue, and then we pack with a posterior polycatheter packing for this. All right, so there are also other technologies that we collaborated with our engineers looking at a more parallel manipulator from a single port development. And certainly, I think the field has expanded with many with newer companies coming up with a single port technology that potentially can be used to apply to ENT head and neck setting. All right, so from our previous papers, where we summarize the surgical salvage rate, I just want to bring to attention that margin certainly is a key prognostic factor. Patients with a positive margin certainly has a risk of 40% for failure versus that of 6%. And the overall local control rate is approximately 66 to 70%. What is concerning is about 40% suffer distant relapses in the future. And among other groups, we look at whether the patient relapse status is a prognostic factor. So we found that residual disease certainly has a better prognosis after surgical salvage than recurrent disease. And you can see the disease survival curve as well as the time to distant relapse are quite markedly different among patients with residual disease. So we define residual disease as patients following definitive chemoradiotherapy for NPCs, and they have biopsy-proven residual disease up to 6 months from the end of completion of definitive radiation. So in this group of patients, if they do fall under the residual category, they certainly have a better prognosis than patients with recurrent disease, which is defined beyond 6 months after definitive treatment. Okay, in the next 10 to 15 minutes, I will just end off with some of the future directions. Certainly, these are just snippets of what is ongoing, but the aim is largely the same, whether we could pick up recurrence earlier, or NPCs, either using liquid biopsies, and I was sharing earlier about the use of Raman spectroscopy, and certainly to use clinical trials, whether we can add clinical trials testing whether we can use adjuvant be it chemotherapy, and now with immunotherapy, certainly some of the studies have shown that in anti-PD-1 antibody in NPC certainly has fairly good promising data in the recurrent cohort. This was a paper published some years back on the utility of EBV biomarkers and liquid biopsies. So essentially, we overviewed this and we found that certainly with the plasma EBV is useful. Serology is also useful, but targeting two particular EBV latent proteins. And certainly we look at some of the newer novel testing, such as microRNA, as well as even next-gen sequencing of the EBV that's detected on your liquid biopsy that can better inform the risk of recurrent disease in this group of patients. This was previously shared, and how we can use Raman spectroscopy using a genetically inspired algorithm across either a protein, lipid, amino acid profiling, and then to help us to use real-time in vivo detection and diagnosis of NPCs. In terms of clinical trials, this was a NCI working group that was done, I think, 2018 or so, and that's where we basically participated in this NCI initiative, looking at some of the gaps in treating NPCs and potentially somewhat the potential trials that we could integrate the use of immunotherapy into the treatment landscape of NPCs. I just want to put in for the recurrent NPC cohort, where I am the co-lead with John Walbrook from Toronto, and certainly we put up some of the possible trials adding either the best institution protocol, be it surgery or re-radiation, and then randomizing them into adjuvant treatment with immunotherapy or observation, and then stratify this group of patients, either the low versus high risk, or treatment with surgery or no surgery. Certainly, I think Raymond from NUS has also this study ongoing, where they are looking at the recurrent treated NPC that may not be surgical candidates, where they give perioperative pembrolizumab with chemotherapy, and then after that decide whether the patient is a candidate for radical surgery, and then follow up with post-op adjuvant pembrolizumab alone therapy, monotherapy. So this is, I think, is ongoing. I think they have some patients accrue in Hong Kong, and certainly we would wait for the result to see whether this is useful. So ideally, we like to pick up patients after NPC treatment with small recurrent disease like that. And that certainly makes our life a bit easier in terms of considering surgical salvage. Just want to highlight, even successful surgical salvage doesn't necessarily mean complete cure. Like in this particular patient, is 5 years out, recurrent disease. And unfortunately, soon after the 5-year mark, you can see there's this endoscopic appearance of irregularity in the sphenoid sinus that were eventually proven to be recurrent NPCs. And the patient is now currently receiving immunotherapy with chemotherapy. So with that understanding, certainly, how do we then understand the biology of NPCs to then integrate immunotherapy into the treatment? You can remember that NPC certainly is EBV, highly EBV positive. And what is interesting, you can see that there are also these infiltrating lymphocytes around the tumor. And many groups have looked at what is the reason and the prognosis of these lymphocytes. And our group and others have shown that the more intense lymphocytic infiltrates of these lymphocytes in the NPC tissue histology portends a superior survival benefit than those with a less dense infiltrating lymphocytes. So other than the lymphocyte population, which are mainly the T cells, so we also asked the question whether what are the other group of lymphocytes, such as natural killer cells in NPCs. And certainly you can see that using a marker of CD56 to stain for NK cells, you can appreciate that some of these NPC tissues have very dense infiltrating natural killer cells in them. So we use the hypothesis whether we could use NK cells rather than T cells to be integrated into treating recurrent NPCs or not. And this is a cartoon taken from Robert Streiber, which basically talk about the immunoediting process, either going to elimination, equilibrium, or the immune escape. So we like to focus on the elimination category. And this is a review looking at the immunology for NPC using cell-based therapy. So we can talk about NK cells, how NK can engage either through direct perforin activation through the stress ligand, or it can be attached to the NPC through the antibody-dependent cellular cytotoxicities, and how NK cells as an innate immunity can then propel the anti-tumor immunity through NK dendritic cell crosstalk, and then propagate this population of the cytotoxic T cells. And certainly, I think the aim is to then enhance and boost the immune system, eradicating NPCs. So I was fortunate to be introduced to Professor Dario Campana from NUS. So he has this proprietary method of expanding NK cell using the K562 membrane-bound IL-15 4-1BB protocol. And they basically were able to expand these large numbers of NK cells for treatment. And this is the NK expansion head and neck cancer clinical trial, where I was co-heading with another oncologist, where we look at this EBV, EGFR specific head and neck cancer, including NPCs. So this collaboration with Prof. Go Buncher from NUS, we did a phase 1 leading to a phase 2. In terms of recurrent NPC, they are not surgical candidate, fail at least 2 lines of chemotherapy, and then must have staining positive of EGFR. This is how the trial schema looks like. You give cetuximab for 4 to 6 cycles, followed then with cetuximab NK in combination, and we evaluate whether the ADCCs where it's being used in this mechanistic explanation of adding NK cell in this particular cohort patients. So in phase 1, we look at safety, feasibility, and phase 2 moving to possible treatment responses, and we have some immune correlates. So we have a small series, about 7 to 9 patients in the end, and this is just how they looks like in terms of the profile. Largely widely metastatic disease. Some are local regional recurrences. They are not surgical salvageable. What was interesting is this small cohort is that we found that patients who had NK cell infusion, and patients who had 2 NK cell infusions certainly has a longer time to disease progression, rather compared to those with just single dose NK infusion. And this is a particular patient with a responder. This patient had recurrent NPC involving the orbital apex. He is already completely blind on his left eye because of that, and with ptosis from oculomotor nerve paralysis. And this is after pre-NK infusion. This is after NK infusion. You can see that was a significant improvement in terms of the ptosis of the third nerve palsy. And on imaging study, you can see that although by RECIST criteria, there's no reduction in the tumor volume, but you can see after the second dose of NK, there was more lucency seen in the imaging on CT, suggesting some tumor necrosis that may be happening. And this is the profile of the NK patients. You can see that among the patient who responded, you can see that he is able to sustain his NK population in the circulation compared to those who are unable to do so. And likewise, when we profile the NK cell in this responder, you can see that the proportion of this mature NK cell are certainly the one that's circulating in this circulation. So we show that NK cell can be used in the proof of principle context for heavily pre-treated NPC patients. We established also that the dose of 1 to 10 to the power 7 cells per kilogram is safe and tolerable, even when used in a combination setting, and the objective response of about 15%, testing the hypothesis of engaging NK cell-mediated and antibody-dependent cellular cytotoxicities. All right, so we understand also that NPC after salvage suffers a high risk of distant relapse. And this is the same for patients who are locally advanced at diagnosis. So we asked the question in this locally advanced patients whether we could reduce the risk of recurrence after NPC after definitive treatment. And our hypothesis is whether we can add NK cells into the conventional treatment with concurrent chemoradiotherapy in locally advanced NPC to eliminate the proportion of patients with circulating EBV DNA from 25% to 10%. This is a cartoon to show how this will look like. Certainly, we want to then kill the NPC using chemo and radiotherapy, and the tumor cell will be then released into the bloodstream. And this circulating EBV positive blood cells can be now tracked using the plasma EBV liquid biopsy technology. And then we can then give NK cells with the idea of mopping out this circulating EBV cells while the patient is receiving concurrent chemoradiotherapy and after finishing definitive treatment. So we did a test, we expanded the NK cell from healthy donors, and we are looking particular on the activated CD56 DEAM population. And we show that the NK cells of these healthy donors are predominantly enriched in CD56 of high purity, and they are also of the matured phenotype with CD16 and 57 positive. So we look at then the in vitro killing of these NK cells, and we found that they were able to kill NPC cells in vitro about 80% using a 5 E to T ratio, 5 NK cells to 1 NPC cell. This is how we can achieve 80 to 90% killing of NPCs. And when we next tested this in an animal model with the cell line derived xenograft model, you can see that in the arm that is treated with NK cell alone or cisplatin, they get equivalent tumor suppression. In the arm receiving NK plus cisplatin, you can see there was an additive effect of the tumor suppression in this group of mice with combination. Next, we look at the rate of growth suppression among this treated with combination NK with cisplatin. We found that certainly the rate of growth suppression was much more pronounced when the tumor is small rather than the tumor is more established and larger. So this gives rise to NK cells. When you want to use this in treatment, it's probably more useful to use it in a minimal residual state where the tumor is slightly smaller, the tumor volume is slightly smaller, rather than a larger tumor, established tumor, where the NK cells may not necessarily be able to eradicate the tumor. And this is just to plot the rate of growth curve. You can see in combination, this effect was only more pronounced when the tumor is smaller. So this is just to show the mice that were sacrificed, the size of tumor indicating the effect. And when we look at the NK cells on the mice that is harvested from the mice, we indeed see that the NK cells are within the tumor of these mice. So let us more confident to design a phase 1 trial looking at combining allogeneic NK cell into the standard arm of concurrent chemoradiotherapy in NPCs. And we are currently working out the trial logistics in terms of manufacturing the NK cells. But in addition to looking at the clinical outcome, we are also keen to look at some of the correlative analysis, seeing whether the NK cells get into the tumor and what the effect of radiation does to the tumor, whether that enhances the tumor towards NK cell killing. We are also collaborating with companies as well as other groups to profile the tissue that is being used for this study so that we can understand the tumor biology and so as to plan what are the areas that we could potentially enhance the use of NK cell therapy, either using engager to redirect the NK to the tumor or developing a CAR NK, either with IL-15 CAR or a combination of all these strategies. All right, so this is just some of the studies that we see. We know that NPC the EBV can either exist in the latent or lytic phase. So there are some drugs that we can show that we can enhance the lytic reactivation with gemcitabine. And we found that if we pre-treat this NPC cell with gemcitabine, we are able to make these cells, NPC cells, more vulnerable to NK cell killing. And this is to show some of the preliminary data unpublished where we show that adding a low dose of gemcitabine plus sodium valproate can sensitize the NPC cells to NK cell killing. And this is potentially related to the upregulation of the NK ligands, ULBP, on the NPC tissues. All right, so this is just to show some of the other strategy that can be used. And the last slide, I just want to show the other portion that can be used is the TILs, meaning that we take the TILs, the T cells taken from the NPC tissues, we take them ex vivo, culture them, and then use them, reactivate them, and see whether they can be used to kill NPC spheroids. So you can see this video of NPC C70 spheroids. You see, and when we add the TILs harvested from the same patient, you can see that the spheroids have eradicated. Sorry, not same patient, but HLA matched patients that the T cells are able to kill the C70 spheroids. All right, to summarize, I believe NPC is an excellent cancer model to use the use of immunotherapy. I mean, our overarching goal is to improve the survival among those refractory NPC patients and potentially minimize relapse in the high-risk cohort. There are many facets of these immunotherapy approaches, and certainly one of our group's intention is to see whether we can integrate off-the-shelf NK in the use of locally advanced NPC patients to minimize the risk of recurrence. There are certainly ongoing work to enhance NK cell therapeutics in NPC and other solid cancers. So with that, I'd like to acknowledge the grant funders as well as the collaborators as well from the various institutions in Singapore, and really appreciate the friendship again with our colleagues here, and really thank you again for the opportunity to present our work. Thank you.
Thank you very much, Professor Chwee Ming Lim, for your wonderful comprehensive talk and with your compelling researches from molecular to the clinical. And I believe that there are questions from the audience that we still have the Q&A session during this time. So please, anyone has questions, you can also post in the chat box or just turn on your microphone, introduce yourself and ask questions. Please. So while we wait, yep, please.
Yeah,
yes,
I think Razif have a question on the chat. Yeah, I can read it out. I think, hey, Razif, you're here. Hi.
Hey, Chwee Ming.
Hey, hi.
Oh, that's Razif.
Yeah, okay. Always a pleasure to listen to you.
Thank you.
So, Prof, if you don't mind, because we know we have a lot of recurrence and they come with advanced disease. So my question is like that, Prof. Chwee Ming, is it worth giving some chemos and then after that we can embark on surgery? Do you have any evidence on that? Yeah.
Yeah, thanks so much, Razif. I believe there is a clinical trial. I think Raymond is one of the co-lead for that, where they use chemotherapy and pembrolizumab as induction before surgery for surgical salvage. And then if the patient is a candidate for surgical salvage after that, then they go through surgery. And after surgery, they give additional pembrolizumab, which is an anti-PD-1 antibody. I believe this is still under a clinical trial, so I don't really have any much inputs on that. Although I've seen one patient who was he's actually Singaporean but treated in Hong Kong, and he went for the trial, and because he was in Singapore, and when I look at it, no more tumor after the induction. So, and true enough, he went for surgery and there was no residual tumor, but that's just anecdotal, just one patient, n equals to 1. But I don't have any more inputs on that. NUS site, I think Prof. Govuncher, who is a medical oncologist, have also integrate VEGF inhibitor. The idea is that they would render a cold tumor hot, because when you block all the EGF, hopefully that will be more blood circulation to the tumor, and that may potentially cause a tumor to be hot and more susceptible to immunotherapy. But I believe this is the recurrent metastatic group and not the recurrent surgical candidates. Yeah.
Great. Thank you. Thanks.
Thank you, Rasif, for the question. Yes. While we're waiting for the question, Chwee Ming, in terms of, because of early detection of the recurrence is very important, and according to research and your experience, what is your proposed surveillance protocol? Do you think you should modify from what recommend that usually in the guideline, like in terms of the interval, in terms of the methods that we use to detect the tumor?
Yeah, thanks so much, Petro. It's a good question. I believe in the line of precision medicine, we probably can't have one size fit all surveillance strategy. Certainly, we know that stage 1 and 2 are probably good players, but also there are, I think our radiation oncologists here at NCC, they use EBV, plasma EBV to really help in that kind of personalization, or I would say stratification approach. Patients who have detectable EBV post-treatment tend to be surveyed more closely, and they are also adopting the protocol done, which was published by the Sun Yat-sen, where they give metronomic chemotherapy with oral capecitabine. So they use a plasma EBV as a way of separating out the so-called high risk versus lower risk players. Beyond that, I think what we typically do is we do straddle with the radiation oncology, so the patient will see the ENT and then see our radiation oncology in the intervals, and we try to space it out so that at each point, everybody, the patient gets to be surveyed and monitored appropriately. But currently, we do not have a protocol based on EBV, but we find that to be particularly useful, the plasma EBV. Yeah.
Thank you, Chwee Ming. Okay, we have Napadon here, the president of society. Please, any question or comment?
Hello, hi, Chwee Ming.
Hey, hi, Napadon. Nice to see you again.
Yeah. Congratulations for your very excellent, brief, and concise and practical lectures. I didn't have the question, but I have some like a comment. That's I agree that nowadays we use the routine EBV viral load. In my university, we use routine in every case with the EBV level to define the disease burden, treatment response, and monitor the disease recurrence. And another things that I may add it, that's about the recurrent case, that we have other options more than the endoscopic surgery and radiation, because in here we have the proton radiation machines. That's I think is another good options because of the technique and the physics different from the conventional radiation therapy. That we can reduce the neuro complications with still deliver the high dose of the radiation to the affected area. That's my comment. Anyway, congratulations and thank you for your lectures.
Hey, thanks so much. Yeah, I think certainly for the radiation oncology, they are also, they have these new techniques like IMPT, proton therapy. Singapore, we do have that, I believe. So we are also actively treating patients, especially recurrent disease, using that. Yeah, that's a great comment. Yeah.
Thank you, Dr. Napadon. There is a question from David asking for sharing the algorithm for screening of individual with positive family history of the NPC. Oh, the wording a bit small on the screen.
So sorry. Yeah, David, sorry, but this was published in the Annals of Academy Singapore. I can try to find a link. It is open access, so you can actually download that. But essentially we proposed among the chapter of ENT specialists in Singapore, and we find that by using endoscopy and serology of IgA versus VCA and EA, we're able to kind of have a algorithm to sieve out the low risk, the high risk based on the risk profiling of the serology, and then guide some of the management for this group of patients. But it's by no means comprehensive, because I don't think there's a unified consensus among our colleagues here. But certainly some of the adjuncts that we found that was helpful was use of MRI for high-risk individuals, as well as for the use of plasma EBV in select setting. So you can Google that. It's readily available in the public domain. Yeah.
Also, maybe in relation to the previous question from Dr. Lam, I think from Malaysia, any role of EBV serology or DNA titer as a population-based screening tool?
Yeah, certainly a good question. In Singapore, we do not advocate general population screening for NPCs. We advocate for familial history for that purpose. But in areas where there are much higher prevalence, such as southern China, where a lot of the screening studies are based, I believe they have shown that use the EBV serology in this context was helpful. So I think the PI is Sun Chao Mei from Sun Yat Sing. I think they have published quite a lot of work along this population screening, but in a very high-risk population in Guangzhou and southern China. Yeah.
Okay, from Dr. Tata, I would like to thank you, Professor Chwee Ming Lim. I would like to ask, is there regimen updates for relapsing pediatric nasopharyngeal carcinoma in Singapore?
Yeah, so I don't really see many pediatric, because SGH, we are more an adult institution. But we do have teenagers. The youngest are treated, diagnosed here is about 13 or 14 years old. So I believe the strategy is largely similar, although I cannot tell you whether the nuances in terms of the regimen for chemo will be different. Sorry, so Tata, I'm unable to give you an exact idea on the flavor for NPC pediatric in Singapore. Although I may refer you to a group in Germany, was quite interesting, because in a recent Gordon meeting, there was this medical oncologist from Germany, where they have been treating NPC for almost 20 decades, pediatric NPCs. And I think they published their experience over that 20-year decade. And it's interesting that they use they use an interleukin as part of the treatment, which was quite interesting from my perspective, because they use chemo, but I believe they also added I can't remember which interleukin was that, but they added an interleukin treatment in their paradigm. But I believe this has been published, so you can refer to that publication. Yeah. But to my knowledge, we have not used interleukin as one of the treatment for NPCs locally. Yeah.
Thank you. And maybe the last question here from Shasikala Sutharsan about the contraindication for endoscopic salvage nasopharyngectomy apart from encasement of ICA, perineural invasion, extensive clivus erosion.
Yeah, so certainly endoscopic exam is critical. We typically will do an MRI, because that gives us added information on the extent of NPC. But just want to give a caveat that NPC, because this group of patients are heavily treated, previously treated with radiation. So sometimes the assessment can be challenging and can only be determined intraoperatively. Meaning sometimes when you dissect the planes, the tissue just feels a bit fibrotic, and you'll be surprised when you do a frozen on that area, it comes back positive. So those are actually bad players, because they tend to be more infiltrative, spreading kind of tumor rather than the more exophytic lesions. But to answer your questions, I think the first one is RT1, so you have to be fairly localized, RT1, T2 maximum. T3 are very selected candidates. So those are the main three, the main indications. Certainly encasement of ICA, those are T4 disease. Perineural, you need to look at your imaging carefully, because if there's significant perineural signs on imaging, you really would not want to consider the patient for surgery. And also, I'd like to draw your attention to a recent publication in the Red Journal, the International Journal of the Red Journal, Radiation Oncology Journal. I think it was published just a month ago, where we looked at the consensus of defining what is surgical candidates and non-surgical candidates. That is also available online. Yeah. So those are my comments to your question. Yeah.
Okay, thank you very much. I think we come to the end of the session. As here we have Dr. Napadon, the president of Thai Society for Head and Neck Oncology, is here. Maybe you have a message in regard to this lecture, and also maybe message to the audience.
Yes,
Please.
thank you. Yes, thank you. Okay, on behalf of the Thai Society of Head and Neck Oncology, and I would like to express thank you and congratulations for this successful lecture today from Professor Chwee Ming Lim, and I hope that this will enhance our knowledge in the nasopharyngeal cancer, and we can have the future connection and collaboration, and together in the Asian country we can have set the new standard and the working group to fight and to find our personalized treatment in the patient in this area together. So thank you everybody to join us. I would like to close the session today.
Wonderful. Thank you very much, Dr. Napadon. Thank you, Chwee Ming Lim, for your wonderful lecture. Also the audience, Mot Razif, Melinda, and all friends from many countries that joined the webinar today. So we still have more webinar. Please stay tuned. You can also observe, follow up with the Facebook of the Thai Society for Head and Neck Oncology. Yes. So อาจารย์จิรสุขมีอะไรไหมครับ
Hello, Chwee Ming Lim.
Okay.
Hi, Charsu. Yep.
Look
hello.
like
It's very nice
Ajahn
to meet you again.
Yep.
And thank you very much for the wonderful lecture and wonderful research that will guide many people, especially the young generation, to follow your step. Thank you very much.
Okay.
Thank you.
Okay, then let me close this session and see you again next time. Stay tuned. Thank you. Bye-bye. Thanks, Chwee Ming Lim.
Thank you, Patrick.
Thanks all. Bye-bye.
Bye-bye.
สวัสดีครับ
Bye.
สวัสดีครับ
Thank you.
Thank you.